Well, we've always had a philosophy of providing the services that our community needs, and so we're very much driven by and responsive to the issues that the community identifies. So for quite some time we've been aware that many of the clients that we see here at the North End Community Health Centre, but also people that we don't even see here, right, who are not even accessing services here, are not receiving the kind of care that they should be receiving around a pregnancy and early childhood development. So we've been concerned about that, and we've been concerned about how we can do something to help bring those services closer to home. So when the provincial government implemented the publicly funded midwifery a couple of years ago, I think it is now, this centre put forward a proposal to be involved at the time, and for a number of reasons, including the fact that we didn't have enough space. We were not selected, and we didn't go forward with that, and others were chosen, and there were 3 sites developed in Nova Scotia. So that first 2 years was coming to an end at the end of last year, and we knew that there was an evaluation being done, that we had a government and a minister who were very supportive of community-based midwifery in the context of primary maternity care. And we know that community health centre model very definitely works, especially if it is, like ours, an interdisciplinary team using a collaborative practice model, so that you don't have any individual care providers kind of sitting out isolated on their own, but they work as a collaborative team, and that has been proven to provide holistic wraparound primary healthcare services that help support a whole range of needs that people may have at any point in their life, but particularly when they're pregnant and new mothers and new families. We thought, well, if they're coming to the point of evaluation and they may be considering putting more funding into this, and now we have some more space, we've rented some more space here, which gives us the opportunity to say, well, how did it go, and what did you find out about the way that it's been implemented to date? And we would like you to consider the possibility of locating another site of implementation than has happened to date. So we did that. We provided that expression of interest, and we remain open to the possibility that if there was funding available, that we would be able to explore that. It makes perfect sense to us in terms of our philosophy and the way in which we currently deliver care and the population who we deliver services to. This end of Halifax, has high levels of poverty, and a population that has experienced, judgment and racism and exclusion and social exclusion. And so they don't feel comfortable accessing healthcare services and other supports in many mainstream institutions. So that means that they tend to have worse health and worse health outcomes than other parts of the city and other parts of the population. So for us to be able to add more supports, especially around early childhood and healthy pregnancies, makes absolute sense with what we do here. Our current catchment area is geographically bound to just this end of Halifax, but we do run programs that take clients who live outside of our area on a needs basis. And so what we would always do in any kind of new program where we would be getting additional resources is to make sure that the program is designed to meet the needs of the clients who are least able and least likely to access services somewhere else. And then if funders are willing to put more resources in that allow us to accept more patients than we normally would because they're coming from outside our geographic area, we would be open to that as long as we got adequate resources to do it, and that we could implement a program that still fit well with the model that we use here and the collaborative practice that we have.
Do you feel like the team here would be a good atmosphere for midwives?
Brilliant. I mean, I've heard midwives say that they would love to work at the North End Community Health Centre. It has a long history. It is very community focused. It has a lot of trust and a lot of respect. And I think that, from what I understand about, the Canadian model of midwifery and the reasons why people are midwives, that to be able to be involved in a really supportive, interdisciplinary, collaborative practice team where there really aren't hierarchies as there are in many other health organizations. We have physicians here who sit and work collaboratively with our dietitian and our social worker and our nurses, and they ask each other for advice, and they discuss cases together, and they manage those cases together. So, that is a very appealing environment for people who want to work in a really community-based delivery model.
And then, so if this were to go forward, what would be a reason why it wouldn't go forward?
Funding is usually a big issue. We're really stretched. We keep taking new patients. Over the last 2 years, we've taken over 1,000 new patients, and we're not getting any more money to do it. So we're really already pushing ourselves beyond our limits. And so we would really need to make sure that this is, adequately funded and supported in a way that makes it sustainable. There's nothing worse than putting a new service out for people and then having to pull it back because, it's not sustainable. So as long as there was adequate funding and we worked out good relationships between the funders and, the other providers, and make sure that we're not this little isolated pocket in a community, that we really have still got all of those supports and services for people. And then I think that, if there are any sort of hurdles to get through around, bureaucracy, or I think the regulations are there, and they allow for a really community-based practice. And I'm sure that we could work with the Department of Health and the Capital District Health Authority and the IWK to bring this together to make it happen. So I think I can't really see any big barriers as long as it's something that everybody wants to happen. I think it's obvious from the media that there is a general demand in Halifax and in Nova Scotia. I think one of the things that is an indication of the fact that many of our clients are not accessing services and supports to help them achieve a healthy pregnancy and to have the best outcomes for them and for their children is that they may not be immediately, knocking at the door and even understanding what this service can do for them. And that's why whenever we think about implementing a new program, the first thing we do is consult with the community, and we ask the community and we work with them to decide, is this something the community wants? Because there's no point in us working to put this model in and get the money and get the midwife and have her sit there and say, but nobody's coming. So, there's some work to be done on the readiness so that the uptake is there when a service is put in. So that may need to have quite a bit of community consultation and awareness and some talks, and go to the library and go to the parent resource centres and get the word out there about what is it a midwife does, and how can that help you, and why is that different from going to the hospital, and maybe you will still go to the hospital, and people need to understand what that can provide for them. Midwives now, under the new regulations, have the possibility to have admitting privileges at a hospital. So in the old model, if you were having a midwife take care of you and you reached a point where you were going to have the baby in the hospital, there would have to be a transfer of care from the midwife to someone who had admitting privileges in the hospital, a family physician or one of the hospital's own doctors. And for a lot of people that was very distressing, because they had this one person taking care of them and supporting them, and right at the point at which they were most vulnerable, they kind of lost that person and got someone they didn't really know. And the nice thing now is that the midwife can go with them and do the delivery in the hospital setting. Because, as I say, we would be following the Canadian model of midwifery, home birth, where it's appropriate, would always be a choice. It's one of those issues about why we need a diversity of different models and different places where people can access service. If you put something only in a hospital, then some people will be comfortable with that and some people won't. If you put it only in a particular community, in a particular part of town that may have a certain kind of reputation or that people are not familiar with, then some people will be comfortable with that and some people won't. I mean, our focus is very clearly about serving a very underserved population. And so I suppose my personal feeling would be that if we had to make a choice, then I would rather see the resources going in to support people whose health outcomes are generally not as good because they have fewer options, than people who have a lot of options and are comfortable in the mainstream system. You know, whether there are enough midwives in the province to meet everybody's needs is a whole different question, and not really one that you know, I can speak to.
But it looks like there are two underserved populations here. That people who need midwife care are also an underserved population too.
Well, yes. I mean, that's the thing. If you create an expectation of a service and then it has such limited access that it creates even more sense of unmet need. Because I mean, if you don't have any midwives at all, then nobody has any raised expectations and they don't think that it's a possibility. But if you put one here and one in Bridgewater and one in Antigonish, then some people get access and some people don't. And even within those programs, there's not many midwives, and so what's their catchment area? And you know, if you've got 2 midwives in Bridgewater, maybe that's enough. Maybe that works really well there. But if you've got 2 in Halifax, that's a much bigger population. So I think that that's one of the issues that happens when you start funding a new program is, as I say, the sustainability. That you have to put it in and you have to know that it's actually going to do more good than it would create frustration and disappointment and a sense of being now an unmet need. Absolutely, because I really do believe that we have a demographic here who the health benefits for them and for their children and their families and their communities of having really good care through their pregnancy and the early childhood has such a significant impact on their health outcomes throughout the rest of their lives that even if the numbers are not great, and this is one of the issues about providing needs-based care, is you may not serve an enormous number of people, but the difference that you make with the people that you do serve is so much better than somebody who has a preference for a certain kind of service, but is probably going to do pretty okay anyway. I mean, I would love everybody to be able to have access to the caregiver that they would prefer to have. But if we have to limit those resources, then the ones that for whom you're going to make the biggest difference, for me, will always win out. With a midwife, you have you know, a very person-centered approach to the care. So, you know, it comes from preconception through conception. You know, if there are issues around, for example, potential for sickle cell, as there are in this population, you may have an opportunity to counsel people before they even conceive. And when you put a midwife into a primary maternity care model, which means that they're working alongside dietitians and social workers, you use those particular skills and expertise of a midwife that are different from a physician and they are different from a nurse. And it has a different focus and it has a different history of practice. And I think that, you know, that in itself has been well proven. And I'm really glad to see that we're not evaluating whether midwifery makes a difference. You know, we know from all of the evidence and all of the research and the history of this profession that, you know, what women need is an advocate and a supporter and somebody who is focused on them and getting them to feel most in control and that they have more choice, not less, throughout this process. And I think it's obvious that when someone has a midwife, that's the outcome that they feel that they've achieved. Not just that they've got a healthy baby, but it was a terrible experience.
Mm-hmm. Or even not even a terrible experience, but just they've got a healthy baby and they go home.
Yeah, and unfortunately for some people it isn't a good experience. You know, they feel very disempowered, they feel very invisible, they feel like it's highly medicalized, and you know, giving birth is not a medical event. You know, many of the complications that can happen, many of the issues around giving birth that may potentially become a medical event, but giving birth in itself is not a medical event. And I think that having a profession that is focused around, you know, the process of giving birth, not as a medicalized event, is an extremely important difference of perception and therefore a difference of experience.